Good evening, everyone, and welcome to today's webinar, the second East Anglian cardiovascular webinar that will focus on combination antithrombotic therapy, ensuring safety and optimizing efficacy. Before we get started, I would like to go over a few items so you know how to participate in today's event. You will have the opportunity to submit text questions to today's presenters by typing your questions into the live event Q&A box, which you access by clicking on the small icon with a question mark on the top right side of your control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. The event will be recorded and both the recording and the slides distributed after the event. I would now like to introduce Dr. Sarah Robinson, the Eastern Academic Health Sciences Network Director of Delivery, that will give a short introduction on some of the Eastern AHSN projects related to cardiovascular disease.
Thank you, Miriam, and it's really good to hear from you and to have our speakers tonight. Just want to check that I'm definitely on.
You are live, Sarah.
Ah, perfect. Thank you.
I was looking
at, I can see Nick's computer in front of me and I saw the delay, so then I was conscious that maybe I shouldn't start. Thank you all for giving up your time tonight. I really appreciate it, and I hope it's going to be a really informative evening for you. I just wanted to start by discussing our purpose as the Academic Health Science Network. We're here because we believe that health is improved by great ideas, but these great ideas can only make an impact when they're put into practice. And at Eastern Academic Health Science Network, we believe that our health is too important to leave change to chance. So, as Miriam said, I'm Director of Delivery, and my team is about supporting local health and care systems to access advice and guidance, and in many cases provide additional project management, practical support and resources to bring solutions to our health and social care practitioners. So I just briefly want to talk about a large project that we had running from 2017 to 2019. It was part of a national programme that aimed to increase AF detection and support the treatment of those who are identified with AF. In Eastern, we distributed over 500 AliveCore devices, and this is part of a system-wide procurement initiative to promote the uptake of digital technologies. We also did various other activities such as virtual clinics, and we worked particularly in Great Yarmouth and Waveney to support the ambitions of the plan to improve the target of the treatment for AF. I really want to talk about the impact for our population, but to recognise that this was not the doing of just the Academic Health Science Network by itself. We worked alongside our health partners, both in primary and secondary care, to have these findings. So I don't want to take credit for this in its entirety. But the AF diagnosis rates astronomically increased. We had 14,280 new cases on top of the 8,622 the year before. And you'll be able to read here about why AF diagnosis is so important. All of our systems in the East of England are now above the NHS target of 80% of patients receiving treatment for AF. And I'd just like to highlight Bedfordshire and the achievements that they've had there as well. So moving forward, because we had such success with the National AF programme, we've developed a much more wider scope programme, which we're entitling CVD Prevention. And that's running from this year and over the next 3 years. As you can see, there are 4 main areas that we're going to work in. We're going to be identifying and treating people with familial hypercholesterolemia. We're going to look at behavioural change support and lipid lowering therapies. And we're going to identify and optimise treatment in people with known high blood pressure. And we absolutely recognise that we need to continue the work of diagnosing and treating people with AF as well. So my presentation is just going to talk about 2 of those work streams, and I'm going to be really brief. But we're really excited that the East of England is involved in a pilot that will start in the new year. And the aim of this pilot is to kind of scale up cascade testing of FH, and that we aim with our local partners to test 6,500 children over a 6-month period in 2021. And this is so important because we know that the early diagnosis and treatment of the parents with statins has a large social and economic impact for these families. We also know that using the 1-year-old child immunisation pathway is a cost-effective way to introduce this testing. So we're really excited in the Academic Health Science Network to be piloting this. We're also part of the Accelerated Adoption Criteria, the AAC programme, and the Rapid Uptake products. And this is about reducing health inequalities and regional variation by ensuring a consistent national approach to lipid management. So as you can see, we'll have the drugs here that we'll be looking at supporting how they can be added into the pathways to bring about patient benefits in our area. And we are absolutely honoured by having an amazing programme manager for CVD, and I've popped his details here. So if you want to hear about any of the programme or any of the elements of the programme, then please do get in touch as well. So I'm going to hand over now to Dr. Paul Flynn, who's the clinical lead for Lipids Clinic at Addenbrooke's. Thank you for your time again tonight.
Dr. Flynn, you are on mute.
Can you hear me now?
Yes.
I'm sorry about that. There was a bad internet connection for a moment. So again, welcome to everybody who's joined us this evening. This is the second, as you've heard, of the East Anglian Cardiovascular Seminar Series, which is designed for all in primary, secondary and tertiary care who look after patients with or who are at high risk of developing cardiovascular disease. And I'm trying to get to my second slide. The format we adopted last time and are using again this time is an early evening webinar with initially a presentation followed by a question and answer session. And I spoke last time on the treatment of lipids to reduce cardiovascular risk. And we're going to hear in a moment about antiplatelets and anticoagulants in people with cardiovascular disease. I've already secured agreement from a speaker to address hypertension next year, and also from Simon Finn at Papworth about atrial fibrillation. And we will aim to cover all of the main risk factors for cardiovascular disease, all of the major cardiovascular diseases, and to look in specific populations. These meetings are jointly organised by a team headed by myself at Addenbrooke's, and also by a team at the Eastern Academic Health Sciences Network headed up by Miriam Silver, and really very grateful for all of the technological support that the EAHSN has provided to this. If you have comments on the format, ideas for future meetings, or indeed ideas for future presenters, do please email either me, paul.flynn@addenbrooks.nhs.uk, or Miriam at miriam.silver@eahsn.org. I'm particularly pleased that this evening Dr. Uni Krishnan has agreed to speak to us. I've watched Uni develop over the last few years as a consultant interventional cardiologist, both here at Addenbrooke's and at the Royal Papworth Hospitals. He runs the he covers the whole spectrum of ischemic cardiovascular disease, running the Rapid Access Chest Pain Clinic, which is an extraordinarily busy clinic, aided by a team of excellent nurses, right through to catheterizing and treating patients with coronary artery disease. And he's going to speak to us tonight on combination antithrombotic therapy, ensuring safety and optimizing efficacy. Uni, I'm delighted to welcome you to this talk.
Thank you, Paul, for that very kind and generous introduction. What I'll do first is share my slides, and I'm hoping that someone will shout out if you're not seeing my slides on screen. So without further delay, thank you again for the introduction and also for this opportunity. The intention of this talk is to specifically address the area where we need to use a combination of antithrombotic medications, and especially in patients with acute coronary syndromes, and particularly those who require stenting. So it is from an intervention cardiology perspective that I will be looking at this, but also I'm hoping that the strategies that I describe based on the evidence that we have and some best guesses, for want of a better description, are useful. And of course, I'm open to discussing and debating the options that I might describe in the next few slides. So just to start with, this is a slide from the last iteration of the 2020 ESC guidelines on acute coronary syndromes. And it is a busy slide, but I just want to draw your attention to the top half of the slide above the dotted line, where they've outlined the various pathways in the coagulation cascade and the various drugs that are in current use, which affect the pathway at various stages, disrupting the pathway. On the bottom half of the slide, you have the antiplatelet medication, both oral and intravenous agents that we use very routinely in practice. What I would also like to describe at this stage are the various terms that people might come across, and it's useful to reflect on what these mean when you see them in the clinical documents that you see in routine practice. So the first thing to mention is antithrombotics. In this presentation and elsewhere should really refer to both anticoagulant and antiplatelet medications. When I say anticoagulants, they include the vitamin K antagonists, such as warfarin, as well as the oral and parenteral agents, both intravenous and subcutaneous, that disrupt the coagulation cascade. DAPT, or dual antiplatelet therapy, as we commonly refer to, indicates the use of two oral antiplatelet agents, usually aspirin plus one other drug, from the list on the bottom left of the screen, where you have in black, bold, clopidogrel, prasugrel, and ticagrelor, which are the commonly referred to agents. More recently, there are other terms that we have to come to terms with, unfortunately, because this is an evolving area. One is triple antithrombotic therapy, which refers to the use of three oral antithrombotics, by which we mean two antiplatelet and one anticoagulant, or in other words, DAPT plus an anticoagulant. Dual antithrombotic therapy, or DAT, as per the new guideline, refers to two oral antithrombotics, and I would like to contrast that with DAPT above, and you can see already how this can become confusing if you're not aware of these definitions, which are now being introduced into guidelines and may filter out into routine practice as we use these terms more frequently. So DAT refers to the use of two oral antithrombotics, one of which is an antiplatelet and the other an anticoagulant. So with that very brief outline of the terms that we use, I would like to point to the dilemma that I face, and I'm sure anybody else who's in the audience faces, when we treat patients who require any antithrombotic agent, where on the one hand, we wish to give them the benefit of reducing ischemic events, and on the other hand, balance the risk of bleeding, which again is an important consideration the longer a patient is on an antithrombotic agent. So the aim of this talk, and to be quite honest, I think the reason what motivated me most is that I deal with queries regarding patients with stents all the time and what to do when something new happens in their life. And one of the key messages I think, which I would intentionally be very blunt about, is something I would wish to convey to the audience, is that stent thrombosis is a very unforgiving complication after an intervention procedure. And I will briefly touch upon the demographics and the prevalence of stent thrombosis and what it means to patients, and then go through a few scenarios which we commonly face, which include the patient who's on established long-term anticoagulation, now requiring a dual antiplatelet therapy regimen after PCI or an acute coronary syndrome. The reverse scenario, where the patient is on DAPT after PCI or ACS, and now having had a new indication for long-term or short-term anticoagulation. I would particularly discuss the long-term anticoagulation because that is what really matters. And the short-term, such as 3 or 6 month therapy, is much more easier to manage. So I will be focusing on the long-term management in the talk. Also, the scenarios where we have to interrupt a combination of either anticoagulant and or DAPT, and what happens when they come in with bleeding complications and how do we manage that. To the right of the slide, I've placed some of the abbreviations I've used in this talk. So in case I didn't mention this before, it is a serious complication to have a stent thrombus. So when we look at the definition of a stent thrombus event, it is defined as is shown in this table, in both in terms of the temporal event as well as the confidence in the diagnosis. So in the rows on the left, what you see are 3 probable levels of confidence in diagnosing it. A definite stent thrombus is one where you have angiographic evidence of having had a thrombus in a stent visualized and treated. It indicates the gravity of the complication when you look at the definition of what is a probable or a possible stent thrombus, where the consensus is that if you have an unexplained death within 30 days of a stent deployment, and we have no other reason to suspect another cause of death, then you have to take it as a probable stent thrombus. So it is quite an important thing not to miss. In terms of the timeline, early stent thrombus is when you have the event within 30 days of the event of the stent, which can be divided into an acute or a subacute stent thrombus as shown, where it is either within the first day or beyond the first day, but within the first month of the stent being deployed. A late stent thrombus is defined as an event which occurs after the first month, but before the first year is complete. And the VLST, or very late stent thrombus, which I'll come to later on, is one thing that really concerns us because it is not as rare as we think. And it is the reason why we have to have a long-term strategy for antithrombotic medication in these patients. So coming to very briefly the mechanisms of stent thrombus, this is from a recent paper. What you see are cross-sectional images of coronary arteries by optical coherence tomography or OCT imaging. And I would like to draw your attention to the top left figure first, and I'm expecting that you can see the mouse pointer on the screen. Those are stent struts which have not fully embedded into the wall or covered by the endothelium, which is how it heals usually. And these are lumps of thrombi sitting on the uncovered stent struts. So lack of coverage of stent strut is a mechanism. As you can see on the top right quadrant, this is a stent that has been deployed, but clearly it's not touching the sides of the vessel, which you see outlined and away from the stent itself. So this is what is described as malapposition of stents, which again is a reason why you can get stent thrombus. On the bottom left, you see these concentric rings of stents which have not been fully deployed. So this is a stent which has been put into the vessel, but not inflated to the appropriate size, causing again a risk of stent thrombus. Interesting, the last one on the right, bottom right, what you see if you look carefully where the mouse pointer is now, are these stent struts outside this new plaque which is developed inside the stent. So this is usually seen in very late stent thrombus where the patient has developed a new plaque inside the stent, what is described as neo-atherosclerosis, and that plaque has ruptured where this red arrow points, like you would have in a de novo standard atherosclerotic plaque rupture, but this is inside the stent. So all of these are mechanisms by which you can get stent thrombi. So looking at one of the largest American registries on stent thrombi, looking at the inpatient mortality for these patients, this is a very high mortality rate for, especially for early stent thrombus. And it is not insignificant for very late stent thrombus either. If you look at the 30-day mortality based on another registry data from the US, what you find is that this 30-day mortality for an early stent thrombus presenting within a month of having had a stent is actually higher by about 40% than the mortality rate after an anterior STEMI. So these are not events to be ignored. These are very aggressive thrombotic events. They are very disastrous events for the patient, with more than 1 in 10 patients dying at 30 days if you have an early stent thrombus. So when we look at the consequence of DAPT discontinuation and the stent thrombus risk, overall incidence of stent thrombus in the current era of practice is seen to be around 0.8% thereabouts over 2 years. And after an acute coronary syndrome event, the incidence of very late stent thrombus, defined as more than a year after the stent has been deployed, is just under 2%. So acute coronary syndrome setting perhaps confers a higher risk for stent thrombus afterwards. If you discontinue antiplatelet therapy within 30 days of the stent, you have an astronomical hazard ratio of 26-fold risk of having a stent thrombus. And whereas in the same registry data, if you look at discontinuation of DAPT after 90 days, interestingly, not a lot of stent thrombi events seem to occur at that time. So what it means is that within the various mechanisms of why you have stent thrombus, discontinuation or interruption of medication seems to confer a risk which depends on when you discontinue or interrupt the medication. And that is an important learning point to take away. Now, in terms of looking at predicting stent thrombi, there are various research projects that have looked at it. This is simply one of the logistic regression risk scoring that has been done. And it is not really bore you with the details of the score, but simply to highlight that of the various risk factors listed here, premature DAPT cessation seems to have a very high risk or confers a very high risk of having a stent thrombus. So then does that mean I'm an advocate for indefinite DAPT? Certainly not. So if you look at the network meta-analysis from a very recent publication, I mean, I would say enough patients when we have almost 80,000 patients in this analysis. What essentially they've done, if you look at the middle of the slide to start with, you have the comparator arm, which is a standard 12-month DAPT, and you're comparing that to multiple other strategies, 2 of which are very short-term DAPT of less than 6 months, usually 1 to 3 months, where you give 3 months of DAPT and then simply follow with aspirin, or 3 months of DAPT and follow with clopidogrel or ticagrelor or prasugrel. Then you have a mid-term where you have 6 months of DAPT, and then you have an extended term where you have 12 months of DAPT. So if you look at the 12 months DAPT, what you find is that although you achieve an improvement in myocardial infarction rates, it is at a significant cost of major bleeding, as you can see from here. Whereas on the other hand, what's interesting is if you have even less than 6 months DAPT, there is no greater incidence of myocardial infarction, provided I would say that the DAPT is given for at least 3 months, whereas you have a significant gain in reducing major bleeding. So I'm certainly not advocating lifelong DAPT by any means, but we have to be nuanced in our care of patients to achieve what's the best balance for a patient. So then coming to the scenarios, and I've clustered these two scenarios together because the risk assessment that precedes our decision making is the same for both of these. So what do I mean by that? So if you look at the reason why we would be concerned about AF particularly is that there is a very common overlap or coexistence of patients with AF and patients with CAD. And it's a very common scenario that we face. So in my mind, when I risk assess patients prior to deciding on an optimum combination of treatment, I have to look at it in 3 domains. One is the risk of systemic embolism. The second is the risk of major bleeding, and the third is the risk of significant ischemic events. And thankfully, there are multiple very well validated and very commonly used scores which are helpful. The first and second on the list, I'm sure people have come across very routinely. Orbit, again, is very well validated, and I think it's worth considering it. And also the PRECISEDAPT score may be the least familiar of the lot, which I do tend to use fairly routinely if I need to use it in deciding a patient's risk. But the key thing is the risk has to be determined in all 3 domains, and we cannot adhere to our partisan lines as any specialist in any department when we decide these things. So coming to the very commonly used CHADS-WASC and the Hasblood score, one of the challenges I have with this is that if you have a patient with hypertension who's slightly older and has a risk of stroke and TIA or TIA, gives you about a 4% chance or risk of embolism, which would indicate that they would benefit from anticoagulation. Slightly frustratingly, the same things feature on the other side, where they have around the same risk of major bleeding. So I have had some challenges in using the Hasblood. It may simply be the way I use it, but I wish to highlight, I'm not saying it is not right to use it, but I wish to highlight the Orbit score, which for me is easier to do in my head because there are less things for me to remember, which is always a bonus. And you're looking at 5 factors here, and this has been cross-validated and checked against the Hasblood with an equal performance index in terms of accuracy of the score. So what you then have is that you can also again divide patients by risk of bleeding into low, intermediate, or high, and with a higher bleeding risk as the score increases numerically. And I'm just putting it out there so for people to use as an alternative to the Hasblood score if people so desire. So that's the second thing I do. Then the third thing is demonstrated by this free-to-use calculator. This study is based on around 14,000 patients or more from, I think, 8 different trials. So they pooled the data. And essentially what you input is what you see on the left of the screen. There are 4 variables, continuous variables to input. The hemoglobin in old-fashioned units, the age in years, the white cell count, again, in the slightly older unit that we used to use, and the creatinine clearance. Also, you can indicate with this box on the left if the patient has had a significant prior bleed or not. And when you press calculate, you essentially see for this example of a 63-year-old man with a good HB and normal white cell count and normal renal function, the question this answers is, first of all, on the top right, what is the risk of bleeding? And this confers a low risk of bleeding for this patient with these variables. Then you see 2 graphs here. On what you're comparing is the blue, which is a extended duration of DAPT, defined as 12 to 24 months of DAPT, compared to the yellow, which is a short duration of DAPT, defined as 3 to 6 months of DAPT. and you're checking whether there's any merit in terms of improved ischemia reduction with the extended 12 to 24 months of DAPT. For this patient, for these variables, it seems to be beneficial to consider at least 12 months of DAPT, where on the bleeding risk side, on the right side here, there is no significant increased risk of bleeding for this patient. Now, by contrast, if you take simply an 83-year-old man with the same HB and the white cell count, and a very commonly found renal clearance about 60 mL per minute in an 83-year-old man, which is not at all uncommon, you find that that increases the risk of bleeding to high, indicating here, compared to the blue, which is an extended DAPT regime, there is no greater benefit in using that compared to a 3 to 6 month regime, whereas the risk of bleeding is significantly higher if you use extended regime. So again, these are very free to use scores with very simple input variables, and it gives us a very good resolution to an individual patient's risk by looking at all three domains of the systemic embolism risk, the bleeding risk, and the risk from having shorter or longer DAPT treatment. And these are the tools that are available, which I would recommend that we use in our practice when we make a decision for patients who require a combination of antithrombotic medication. Now, when you look at the first scenario that I mentioned, which is patient is on long-term anticoagulation and now requires DAPT after PCI or ACS, the ESC has published in August 2020 a guideline which mentions the use of these agents in combination. What you see where the pointer moves on the top, I would like to draw your attention to the different colored arrows. The green arrow is the NOAC arrow, which is the oral anticoagulation arrow, where it is meant to be long-term, and therefore it takes you through the various time points on these lines: 1 week, 1 month, 3 months, 6 months, and 12 months. And because this is long-term, this is continued uninterrupted. You then have the second agent, which is the antiplatelet agent that is given in combination with aspirin, either clopidogrel or ticagrelor or prasugrel. Now, if you're using a NOAC, this agent should only be clopidogrel. There is no indication to use ticagrelor or prasugrel, which are much more aggressive antiplatelet agents, in combination with warfarin or other anticoagulants. And that is an important thing to mention. They're suggesting that the aspirin use is curtailed to a month and even perhaps less than a week, although I have some issue with that, which I'll come to later. By comparison, if it's a medically treated ACS with no stents in place, as you can see, the aspirin arrow has disappeared. So we are much more comfortable as interventional cardiologists to have simply dual antithrombotic therapy or DAPT without the aspirin in patients who do not have stents. So you can see that the merit of giving triple antithrombotic therapy comes mainly in patients who have a stent in situ. And again, beyond 6 to 12 months, you can stop the antiplatelet agent and simply continue with the anticoagulant. In stable coronary artery disease, I still haven't gotten used to calling it CCS, which is chronic coronary syndrome. So it just doesn't roll off my tongue, apologies. So I call it stable angina. If you have an angioplasty with a stent, you still require a short course of triple antithrombotic therapy, but then you can drop down after a month to DAPT and then single agent after 12 months. Now, the issue I have with the 1 week restriction of triple antithrombotic therapy is that this is what the guideline says, but it does not, it is not supported by the evidence. And I'll mention that very briefly. So what you know is from the, I would say, arguably the biggest and probably the best trial done to look at the combination antithrombotic agents that we have on offer from Augustus, published last year. And we had more than 4,500 patients who either had an ACS or a PCI and required anticoagulation. They compared two different questions, or they hypothesized two different things. One is whether vitamin K antagonists such as warfarin is better than a NOAC, in this case apixaban, and whether dual antithrombotic therapy was better or worse than triple antithrombotic therapy. So the way the trial was designed is shown in this box here at the bottom left. So clopidogrel was given to all. Then you had a 2x2 factorial trial. So you either have vitamin K or apixaban and aspirin or no aspirin. What you then have are 4 groups where you have triple antithrombotic therapy, where the anticoagulant is vitamin K antagonist, triple antithrombotic therapy with a NOAC, DAT with clopidogrel and warfarin, and DAT with clopidogrel and a NOAC. So you get 4 combinations. So you are seeing whether triple therapy is useful and which is the better anticoagulant. And the pertinent graph, which is actually from a publication later on this year, is this. So to draw your attention to the important finding in the graph, one thing is to highlight the 30-day line, which is this red line. And if you look at the green asterisk graph, which is triple therapy with apixaban and aspirin, which is this bottom yellow line, and compare that to the blue cross here, which is without aspirin, apixaban and clopidogrel alone, you find that the stent thrombus events in days from randomization is actually more if you don't have aspirin to start with. So to me, when I look at this data, which is to my mind the best available data, 1 week of triple therapy does not cut it. I think it is safer to have 1 month of triple therapy and then drop off the aspirin and continue with the DAT with clopidogrel and apixaban. So that is based on not just my opinion, that is what the data says based on this trial. So this is what I would recommend as a result: triple therapy for a month, then clopidogrel plus NOAC for the remainder of the 12 months post PCI. If you have the reverse, again, I would say risk assess, look at systemic embolism, major bleeding and ischemic events, as I mentioned before. You then have the first month post PCI, where you give triple therapy with a NOAC. The second phase, which is 1 month to 12 months post PCI, where you have dual therapy with clopidogrel and a NOAC. And then the long phase, which is more than 12 months post PCI with a stent, where you have monotherapy with a NOAC alone. It's important also in certain individuals, depending on their bleeding risk, to consider the use of PPI, especially if more than 65 years of age. And I'll mention why I say 65, and it will come in a later slide. Now, do I have any particular reason to favor apixaban? Well, only based on data. So what is shown here is a network meta-analysis of nearly 40,000 patients, about 13,000, I think, in each group, comparing 3 different anticoagulants: apixaban, dabigatran, and rivaroxaban. I've not shown the data which looks at thromboprophylaxis, where all 3 have a similar performance. So there's not really a better agent of the 3, and they're all equally effective. But when you look at major bleeding and GI bleeding, apixaban clearly seems superior in this meta-analysis compared to both dabigatran and rivaroxaban. And this is mirrored in other real-world data out there, which compares these 3 anticoagulants. So which is why I mention apixaban as my choice of NOAC. It may simply be because it is a BD dose and it's effective and it's quick to wear off when you stop it. But for whatever reason, real-world data seems to favor apixaban over the other agents. Now coming to the situation where we have to interrupt anticoagulation or DAPT or a combination. So I think when I'm asked the question, can we stop the antiplatelet therapy? My answer is, well, it depends if there is a stent in situ or not. If there is a stent in situ, then we need to have a plan. Even if they have had an ACS or an NSTEMI or some kind of type 2 event, and if they don't have a stent in place, then I'm much less anxious about interrupting antiplatelet therapy. So the first thing would be to really counsel the patient regarding the risk and benefit of whatever surgical or intervention procedure that they're going to undertake or undergo. And then the second thing is to think in terms of the temporal position of this interruption. So if really you need to interrupt less than a month post PCI, I would be very concerned because, as I mentioned before, there's a 26-fold increase in stent thrombus with a 13% 30-day mortality in these patients. So if you're going to counsel them regarding surgery in this period, we need to mention the reality of more than 1 in 10 chance of mortality if they have a stent thrombus. And that is important to mention. If it is emergency surgery, there's not much we can do about it. Now, none of the surgeons in the audience will like this proposition that we favor clopidogrel, but I'm just mentioning my visual thinking as a cardiologist that if I were to ensure antiplatelet effect, I would prefer clopidogrel. But I know for a fact that the majority of surgeons I discuss such patients with would be happy to operate on aspirin, but they would not be at all happy to operate on clopidogrel. So I don't think I'll get my wish in this situation. But if it's emergency surgery, we have to do what we need to do. Now, on the other hand, in my opinion, slightly contentiously, I would say if there is elective surgery planned within a month, then I would say it is mainly a concern of failure of communication. And I would say that is from the cardiologist perspective that I should, as an interventional cardiologist, check that the patient does not have a planned surgery in the first month after my stent. And that is a routine question that I ask and all of my colleagues ask and the trainees ask at Papworth before we put a stent in. So I think personally, my impression is that we are, as a group of specialists working in interventional cardiology, fairly aware of this need for any elective surgery. And I have had on the handful of occasions when things are unclear, I've had actually, I have picked the phone up from the cath lab and rung a surgeon and the specialist to check what they wish to do with the patient. It's especially important in closed spaces such as ophthalmology. When they're expecting to have eye surgery, I find it's important that they may not be able to do it without antiplatelet cessation. So I do make it a point to discuss before I put a stent in. Now, if it is beyond 1 month, I think we have a little bit more room for maneuver. Preferably, I would say delay till more than 3 months post PCI, because as we saw from the previous data, beyond 3 months, stent thrombus arising from discontinuation of or suspension of DAPT alone doesn't seem to be that high. But I would certainly say continue the aspirin. I would never want to stop both agents. The other antiplatelet, whether clopidogrel clopidogrel or ticagrelor or prasugrel can be stopped. And if they're on anticoagulation, the decision to stop depends on the indication. And the decision to bridge depends on the indication. And that is something that I would not profess any expertise in. And I usually seek advice from the hematology team and look on the guidelines we have on Merlin about when to bridge. Now, if it's beyond 12 months, I would definitely again say continue aspirin uninterrupted in the perioperative period. Stop the other antiplatelet if for some reason they are still on DAPT, which the majority will not be. And the anticoagulation decision depends on indication. Now, there is an emerging cohort of patients in this time frame where they are on anticoagulation alone now because it's beyond 12 months. You stopped all antiplatelet. And then if you stop the anticoagulant as well, suddenly they have a stent in place with no antithrombotic agents at all. So slightly contentiously perhaps, I will mention my proposed plan for bridging them with aspirin, which I'll come to in the next couple of slides. So before I mention that, this is a very useful diagram from the previous iteration of an ESC guideline from 2017, if I remember right, where they had a position statement on the use of DAPT. And in that, they mentioned the time point before surgery where you can safely stop the antiplatelet agent. As you can see from this white arrow at the bottom, aspirin is continued uninterrupted and prasugrel needs to be stopped 7 days as highlighted in the screen, clopidogrel 5 days, and ticagrelor 3 days prior to surgery, and then restarted as soon as possible after surgery if they are within 12 months of having had a stent. Now, what if they are beyond 12 months, and how do we address that? So in that regard, first thing is, I always ask this visual question: can you do the operation on anticoagulation? The answer can vary, and there are a spectrum of answers, which some of which are unrepeatable, but usually they would not be happy for any major surgery to take place without stopping anticoagulation. In which case we need to ask, do they qualify for bridging? And if they do, that bridging is sufficient as an antithrombotic agent. However, if there is no bridging required, but suspension of the agent is required, then we have to maneuver this very carefully. As far as I know, there is no specific RCT evidence to tell us what to do. There are case series using IV antiplatelets, eptifibatide, which I've used very rarely, I would say on a handful of occasions in the last few years. This is a GP2B3 or glycoprotein 2 beta 3 alpha inhibitor, which inhibits the final binding of the fibrin filaments to platelets and inhibits clot formation. And the other agent, cangrelor, which I've never seen or used, which is an intravenous antiplatelet agent. There are cases which mention the use of this to bridge with variable success. So again, unfortunately, slightly controversially, I'm going to mention a level 5 opinion with the appropriate biohazard signaling, which is my opinion on what could be a potential way of getting around this. So I tend to start this about 5 days prior to surgery, where I would recommend that you give them a loading dose of aspirin and then continue that till about 2 days or 48 hours prior to surgery, where usually the NOAC is stopped if they're on a NOAC. And you continue the aspirin throughout surgery as shown, and then restart the NOAC when safe to do so at the earliest opportunity after surgery, at which point you can stop the aspirin. Now, as I said, this is very much a personal opinion. I do not know of a guideline that tells you to do that. I'm putting this out there mainly to be criticized and to discuss this and to see what my colleagues think of this as an option. I'm not aware of any other data out there to support this, but I'm interested in the thoughts of the expert audience. Now, the last bit you'll be glad to know is regarding the bleeding complications and the prevention and management thereof. Now, if you look at the risk of bleeding post-PCI, what you find is that there is very much a temporal distribution to this. And most of the very bad bleeding, whatever kind of bleeding it is, whether gastrointestinal or other, seems to be within the first month, which makes me wonder whether as interventional cardiologists, we are not making a very good assessment of the bleeding risk of patients. I don't know, but that seems to be the trend overall. What's very interesting also is that when you have a bleeding event, it increases the risk of death, of course, but also MI quite significantly by having that bleed. Now, part of it may be simply from exsanguination and having a type 2 myocardial infarction from watershed infarction. But I also think part of it is from having a significant risk of stent thrombus from having stopped the antithrombotic agents because they have come in with a bleed. So it is important that although they have had a bleed, we need to take stock of the relative merits of stopping all antithrombotic agents and continuing at least one of them versus the risk of stent thrombus and the risk of hemorrhagic complications. And that is a discussion that has to be very nuanced, very personalized for the patient, and very much multidisciplinary to arrive at the best combination of circumstances for an individual patient. Now, I would say managing a serious bleed in patients with stents starts before the stent. And what I mean by that is I do, and I know my colleagues do as well at Papworth, we always check about the history of bleeding. I always check the HB and the MCV. For me, I would not really wish to put a stent in someone with a microcytic anemia until I know that they do not have a GI source of bleeding. As Dr. Flynn mentioned earlier, I do the rapid access chest pain clinic at Addenbrooke's, and it is not uncommon for me to raise a suspicion of a colon cancer in a patient who comes in with a HB of 111 and an MCV of 76, and a colonoscopy later tells you why they have angina. So it is something that I'm aware of, and it is something that I do try and not miss, and also to assess the frailty of a patient, which is quite an important factor to consider before we embark upon committing patients to antithrombotic agents. The other thing is before discharge, after they've had the stent, I would start a PPI if applicable, by which I mean I refer to the Lancet paper that I've referenced here, which looked at the number needed to treat to prevent a major GI bleed in patients with PPI. These were all comer patients across the age spectrum. I think from memory, if you're under the age of 65, you have an NNT of more than 330 to prevent a major bleed by giving PPI. Whereas if you're over 85, the NNT is less than 30. So there is an order of magnitude difference depending on who you're treating. So unlike what the ESC guidelines says in August 2020, to give PPI for all patients post-PCI, I'm not sure that is really necessary, but certainly the older patient, especially in patients in their 80s, I would be very keen on them having a PPI, even if they've not had any previous aseptic disease, given the very low NNT to prevent a major bleed. I would be again interested to know what my expert colleagues think in other fields about these. Now, if they do have a bleed, I think it's a commonly shared approach to say that you transfuse, you intervene either surgically or endoscopically if it's a GI bleed, and you continue at least one antiplatelet if you can. Especially when they come in less than a month from the bleed, this is perhaps scandalous and even blasphemous to say to continue an antiplatelet, but I would certainly wish to have a discussion with my GI colleagues and with hematology if appropriate, or my surgical colleagues, to see what can we do in practical terms for that individual patient who comes in with a bleed, rather than a blanket approach to stop everything and risk a major cardiovascular adverse event with a very high mortality. Now, when it comes to what to do after the bleed, I think I would say if it's less than a month, restart the DAPT as soon as possible. Consider clopidogrel as monotherapy, although I would want to see through a month if I can. And if it were to be beyond a month, where the risk of stent thrombus is significantly less, you can certainly de-escalate to clopidogrel alone, and even intentionally switch to clopidogrel from aspirin if the source of bleeding is a GI bleed due to an aseptic disease complication. What is important to say is that this is simply an opinion in this table, which again needs to be discussed on an individual patient basis. And also that discussion is what I wish to highlight rather than suggest that this is an easy answer in this very difficult scenario with a very sick patient. If they have an anticoagulant indication, for atrial fibrillation, in select patients, it may be appropriate to consider discussion with our structural cardiologists at Papworth to think of left atrial appendage closure devices in niche patient groups to then avoid giving them long-term anticoagulation. So it is simply to give you an overview of what could be a potential strategy for these patients when they come in with a bleed. Now, the very final thing I would like to mention is the addition of NOAC to antiplatelets for secondary prevention of stable CAD. So what I would say, without sounding very dismissive, is that for the vast majority of patients, there isn't really a need to give long-term NOAC with aspirin if there is no other indication for a NOAC, simply because they have coronary disease. If you do it, there are very select, young, fit, low bleeding risk with a group of patients with very high risk of coronary disease who may benefit from it, but it requires a very clear and thorough assessment of the bleeding risk, and you require a strategy to de-escalate as they advance in age or if they have adverse events. So unless you have a very careful plan for each patient, it is not simply a case of starting an additional agent and then forgetting about the patient. Now, the reason why I say that is I'd not expect anyone to read the details on this slide, but it's simply to show you the forest plot on the left, which shows you that for ischemic prevention, a combination of low dose of rivaroxaban to aspirin is actually better than aspirin alone, which seems convincing when you look at this. This is, of course, in the main paper. Interestingly, what's in the supplement, which I have to dig out, is a mirror image of that graph, where the bleeding events are certainly skewed in favor of aspirin monotherapy. So yes, there may be a role for addition of low dose rivaroxaban to aspirin in secondary prevention of CAD based on the graph on the left. However, for the vast majority, this would not apply because of the significant bleeding risk. I think I would stop there because it's been quite a data intense talk, I feel. I'm quite happy to take questions. Thank you.
So thank you very much indeed, Uni. A really very complicated area and clearly a very relevant area for many of us as we try to steer between the rock of a stent thrombosis and the hard place of an increased risk of bleeding, both of which could be dangerous to patients. Now, there have been quite a number of questions that have come in, and we'll work our way through them. So do keep sending them in, and we'll work through them. So one of the questions, Uni, was how confident can people be that stent thrombosis is a cause of death when it occurs a year after the stent has been placed? Is that always based on post-mortem data, or how is that diagnosis achieved?
Yeah, so I think it is, the definitions is where this question arises from. So what I would say is that most of I think unexplained sudden death, the reason why the definition is as it is because in a patient with a stent who has a sudden unexplained death, a stent thrombus is always a contender. However, in terms of the diagnosis of very late stent thrombus itself, it's not that the majority of VLST, if I may use that acronym, come in dead. You do see them come into the cath lab as a primary. I remember one last week who came 8 years after his stent. So in the majority of patients who actually survive to hospital, when you have a very late stent thrombus, the diagnosis is based on the angiographic confirmation of the detection of a thrombus sitting inside a stent. And oftentimes we undertake intracoronary imaging by either OCT or intravascular ultrasound to look at a mechanical reason for this to happen. Sometimes we find it, sometimes we don't. And sometimes this is superadded thrombus on a severe restenosis inside the stent, and sometimes it's one of the 4 mechanisms or many mechanisms I mentioned earlier. So it is not as if these are blind diagnoses, but there may well be a small group of patients where you do not identify any other cause of death, and they have had a sudden cardiac death. In those patients, I would expect that the autopsy would yield an indication or evidence of intracoronary thrombus if that is the case, but that is certainly not the majority. The majority are patients who actually come into hospital and have an event, and we can see the thrombus on the angiogram.
Very good. Thank you. Thank you, Uni. We've got a question from a general medical registrar who would like you to reprise. What are the symptoms? What's the presentation of somebody with early or acute stent thrombosis? How does it present?
Thank you, Doctor. That's an excellent question, and it is only in the interest of time that I did not mention that in my presentation. That's an important question. So when we think about 2 stent-related complications, broadly speaking, we have in-stent restenosis and in-stent thrombosis. Restenosis has a more indolent, slow buildup of plaque inside and presents with stable angina, sometimes as an acute coronary event. But in-stent thrombosis or stent thrombus, they are fairly acute events, and they present usually as a STEMI, and they usually present with very marked signs of an acute coronary occlusion. So it is not a subtle diagnosis in the majority of patients. If a patient has an out-of-hospital cardiac arrest and they have a history of previous stenting, assume this is in-stent thrombosis until we know otherwise. So those are the kind of patients who have sudden cardiac death or present as a STEMI, and those are the 2 very common scenarios in which they present. They are not the patients who come in with slowly progressive stable angina, and I'm hoping that answers the question.
Good, thank you. If it doesn't, please do type out a supplementary question. And then there's quite a few questions about this whole issue of interrupting therapy and how complicated that is for non-cardiologists to chart their way through. So somebody's concerned they have a patient who's got a stent and they have paroxysmal atrial fibrillation and they're on apixaban, and then they're going to have have elective surgery. How can we ensure that the right advice is given? Is there a place for specific advice sheets for the patients or cards for the patients, or is this something that can be flagged up at pre-assessment clinics? What would be your best suggestion, Uni?
Yeah, so I think it is not easy, and the reason why it is not easy is that if I can think of the most effective strategy is to contact the cardiologist who's put the stent in. And that is usually easy where we work, but may not be easy in all places where the audience is from today. So if it is possible, speaking to the cardiologist who's put the stent in is the best way forward, because they will know exactly what stent was put in, what is the strategy, what should be done. In this scenario where this is paroxysmal AF, which I assume is non-valvular AF because they're on apixaban, and the only reason why they have a stent and they're only on apixaban is because it's more than 12 months after the stent. Because for the first 12 months, we would routinely advise a second antithrombotic agent, which is usually clopidogrel with the apixaban. So we have the scenario which I mentioned earlier of the patient having completed 12 months of DAPT. They are now 2 or 3 years beyond the stent, and they are solely on apixaban monotherapy. Now, there are colleagues of mine who would prefer, as interventional cardiologists, to give these patients lifelong aspirin and apixaban. And that is certainly one way of approaching it, so that when you come to an elective surgical procedure, when you stop the apixaban, you have the backup of the aspirin. The reason why I do not wish to advocate that as a blanket solution is that when you look at the COMPASS data, which is the last bit of data that I showed, when you add 2.5 milligrams of rivaroxaban, which is about an eighth of the dose for AF, 2.5 milligrams of BD actually, when you add that to aspirin, you get a significant risk of bleeding. What hope then of adding aspirin to a full dose apixaban or rivaroxaban? That is why I'm hesitant to advocate that. So in those circumstances, when you have a patient who's on NOAC alone and you have to stop that and they have no other antithrombotic agents on board, I think the best thing is to seek advice from the local cardiology team and think about the reality that any patient with a stent should have one antiplatelet agent throughout their life without interruption to stop them from having a very late stent thrombus. So it is perhaps not a satisfactory answer to the question. The guidelines are variably effective is what I would say, but the DAPT guidance, so if you search on Google ESC, European Society of Cardiology, 2017 DAPT guideline, I think it was published in July or August of 2017, if I remember right. That is a fairly useful document where I've derived that slide about the 7, 5, and 3-day plan for stopping the clopidogrel or the prasugrel. That does give you some idea of how to bridge. But this is an emerging group of patients because we have, as by routine, we have given antiplatelets lifelong alongside warfarin before the NOACs came on board, with lifelong dual treatment with warfarin and aspirin for all patients post PCI. That changed to not needing the aspirin routinely only, I think, in 2015 when the AF guideline was revised at the time. So this is a fairly newish cohort of patients who are only on a NOAC monotherapy. And we are now finding some of these patients who have stopped their apixaban for dental procedures, especially because that is the most dangerous thing I feel. They stop it for dental procedure outside hospital without much discussion with anybody in hospital, and they come in as a very late stent thrombus to Papworth or to a tertiary center with a STEMI. So it is an important group of patients. I do not think that I'm over-egging the risk of a stent thrombus in this group of patients. If the audience, even if they're not in cardiology, if they're aware of this possibility and raise it with the local cardiology team, that itself would be a start.
And kind of continuing in the same theme, we've got one question where one of our audience called Monica has seen where triple therapy has been given, but with reduced dose DOAC in the post-PCI phase. Is that common? I mean, from what you've just said, Uni, that doesn't seem to be a standard approach.
Yeah, so I think that depends. So when I mentioned the three things that we have to assess, risk of ischemia, risk of bleeding, and the risk of or the benefit versus risk of long-term dual antiplatelet therapy. So when we think of that, my approach has been guided by the Augustus trial quite a lot, and that was to me a genuinely practice-changing trial, because the data from Augustus is fairly robust. Before Augustus, it was very much a kind of free-for-all where we did various combination of things. But now, I think there is fairly good evidence from that trial, although I admit it's a single trial, that you can afford not to have all these various combinations and have triple therapy for a month, followed by clopidogrel and apixaban. Now, in that scenario, the reduced dose apixaban is for the patients who require reduced dose apixaban, by which I mean if they satisfy 2 of the 3 criteria for 2.5 milligrams BD of apixaban, which would be age more than 80, weight less than 60, and I think EGFR less than 30, I think I can't remember. So you need to have tick 2 of 3 boxes, or I think it's creatinine more than 133, if I remember right. So then if you have those, 2 out of 3, then you go with the lower dose. I don't particularly see a reason to deviate from a clearly defined indication for lower dose and simply pragmatically give a lower dose. I'm not sure that is actually evidence-based.
Okay. Some relatively more straightforward, I hope, questions to answer. One is the advice different depending on whether it's bare or a drug-eluting stent?
So I think, so if you look at the long-term data, there is not much difference. So the only merit of a bare metal stent historically has been that the initial phase of DAPT need not be a lot longer than a month. Now, beyond a month, if you look at very late stent thrombi, there isn't much difference between a very late stent thrombus in a drug-eluting or a bare metal stent. Now, more importantly, the most recent trial published about a month ago was the Science 28. The Science is the name of a drug-eluting stent. And Science 28 was one of the trials which has actually looked at 4 weeks or 28 days of DAPT in a drug-eluting stent. There have been other previous trials as well, which have shown that even for a drug-eluting stent, you don't need a full protracted 12 months of DAPT. So with improvements in the stent architecture, with improvement in the stent polymer, which is one of the thrombogenic components of a stent, with the various technical advances that have happened over the years, the current generation drug-eluting stents are by no means any more risky in terms of long-term risk of stent thrombus compared to bare metal stent.
And then I think also an excellent question from Monica. What level of thrombocytopenia would lead you to modify these suggestions, Uni?
Yeah, so this is something I asked my hematology colleagues, to be quite honest. So I think from what I understand, and if there are hematologists in the audience, please feel free to educate me otherwise. What I understand is that until they have a platelet count less than 40, I would continue at least one antiplatelet after a stent. So again, this depends on, it's not a simple, straightforward answer because it depends on when we are thinking about this. If it is within the first month after a stent, I would really want to discuss with the hematologist about the risk of stopping all antiplatelets. And unless there's something like an AML scenario or some kind of maybe an immune thrombocytopenic purpura or something like that, where there is a disastrous fall in platelets, maybe it is an individual decision. But simply because if they have a platelet count less than 100, I wouldn't drop off the antiplatelets. Before I stop the antiplatelets, before I consider stopping the antiplatelets, it has to be at least less than 50. And I would then do that after discussion with hematology and ask them what can we get away with, because we know that sometimes just because they're thrombocytopenic, they may not have an excess bleeding risk, and you should not have a knee-jerk reaction to then suddenly stop the antiplatelets.
Thank you for that. And quite a specific question and hopefully a relatively rare situation. What about a patient who is pregnant and who requires a PCI? So case by case basis.
Yeah, so no, I think the best answer I can give is that the reason why a patient who is pregnant or of the childbearing age coming with an ACS is usually as a STEMI, and that is because of a spontaneous coronary artery dissection. It is unusual in what we traditionally consider as childbearing age for them to have sufficient cardiovascular risk to have atherosclerotic coronary disease. Now, for every statement, there is an exception, and I immediately recollect a 43-year-old I saw about 6 years ago who had a STEMI and had proper coronary disease. But those kind of exceptions apart, the mechanism of disease is usually different. The reason for stenting is usually very much less. They either have a dissection or they have a remote embolus, paradoxical embolus, or other such reasons to have a coronary event. But if you stent them, I think this where again, I don't think we live in a void. I do think that we can always get an opinion, and I have previously used our colleagues, for want of a better description, ask them while the patient is on the table as to what can we do to strategize these things. So the important thing for me is not to make decisions in vacuum or in isolation and to talk to people who know better.
I think that's a very good point, Uni. And unfortunately, as you say, these situations are relatively few and far between. And there's a very good question here about patients who have atrial fibrillation, are known to have underlying coronary artery disease, but who don't have a stent. So they're going to be anticoagulated for the AF. Is there much benefit in them being on an antiplatelet as well?
No. So stable coronary artery disease, where there is no ACS indication, that is particularly addressed in the 2015 iteration of the AF guideline. I have to confess, I did not read the 2020 guideline in full yet, but the 2015 guideline was making it very clear that beyond the first 12 months after an acute coronary event or after a stent deployment, there is no great merit or indication for additional antiplatelet agents in the presence of stable CAD when you're on anticoagulant.
Thank you. That's very helpful. And then we've got a suggestion here. So if you've got a patient who has atrial fibrillation, they have had a previous stent, but it's more than a year ago, is it reasonable to switch to therapeutic low molecular weight heparin and stop it a day prior to the operation, or possibly 2 days before an elective surgery? Is that reasonable, or should it be discussed with cardiology?
If you have a stent, you should not ever stop antiplatelets. So anticoagulant, I don't think, cuts it unless you then continue the anticoagulant in the perioperative period, by which I mean pre, intra, and post-operative period continuously. Unless you're going to do that with IV heparin or some such, where you have therapeutic anticoagulant effect, you should have an antiplatelet. There is no point stopping the low molecular weight heparin 2 days prior, letting it wear out and have a stent without any protection.
Good. I think that's a very clear message. So thank you for that, Uni. So Uni, you've given a very clear and very comprehensive overview of a very complicated area. And I think all of us will appreciate the chance to go over the talk again when it's disseminated, and indeed some of the slides, because you do cover a number of scenarios, and they're common and they're important. And thank you also for the excellent answers you've given to all of the questions. I'm going to wrap it up now by thanking everybody again for their participation, wishing everybody a happy Christmas and New Year, and we will be sending out details of the future seminars for next year. As I say, if you have ideas for speakers or talks or discussions, then please do email me. And I'm just going to finish by thanking Uni again for all the hard work you've put in. I know you were on call last night, beavering away. So I'm impressed that you haven't, that you've been able to do this and give us such a clear talk tonight. So I will clap on behalf of everyone.
Thank you, Paul. I appreciate it. Thank you for the opportunity.
I don't get that feedback at the end. Thank you again, Uni, and thank you, everyone.